I'm starting the recording.
It is still saying host disabled participant screen.
सैनिक भाई स्क्रीन शेयरिंग आपो ने
Sejal, Dr. Paul is here.
Yes, sir. Good evening, sir.
Good evening. Can you hear me?
Yes,
sir.
sir. So nice to see you, sir.
How are you, Paul?
Sunita is already here.
Sejal है सर, अपनी सेजल है, कुछ भी करेंगे उसके लिए.
Thank you, madam. Thank you, sir. Thank you, sir, for joining. Thank you, ma'am. Please,
Dr. Host, could you please start the screen sharing?
Nainika Gaur, please, Shrenik, make Nainika Gaur a co-host.
Okay, madam. Done.
Yes,
Yeah.
you're co-host, Nainika, now.
Yes. So should we start?
Yes, please.
Yes, miss. Great, great. So, good evening, everybody. And I welcome you all to FOGSI Endoscopy Committee, which has organized a webinar on abnormal uterine bleeding with Ahmedabad, Aurangabad, Nashik, Navsari Obstetrics and Gynecological Societies. And I welcome all the guests of honors, the dignitaries, all the speakers, and our dear speakers, along with all the delegates who are here to listen to these great people. So we have amongst us Dr. Sejal Naik, who has worked really hard and coordinated this entire event beautifully. And we have our seniors and post holders from various societies, Ahmedabad, Aurangabad, Nashik, Navsari. And we have our guest of honor. I would like to introduce Dr. Sunita Tandulwadkar, madam, Dr. PG Paul, sir, and Dr. Sneha Bhuyar, madam. I welcome you all. Dr. Sunita Tandulwadkar, madam, she has been the head of the department at
Nainika,
Clinic.
don't waste academic time in our introduction. The team all knows us. So don't waste our
Okay.
time with our CVs and all.
Should we start directly?
Yeah.
Okay, great. So I would directly then start with our first session, which is medical management of abnormal uterine bleeding.
Nainika, give us a chance to speak 2 minutes and then we leave.
Sorry. क्या कह रहे हैं मैम?
Nainika, the madam doesn't want a formal introduction. She's very well known. She's a president-elect and she's the lady in red. So we would like to hear some good
Yes, ma'am. We
something.
would like to hear few words from the ma'am.
And
Can
can
we
stop
stop this
screen
screen
sharing.
sharing?
I should stop sharing. I will have Dr. Sunita Tandulwadkar, madam. I please invite you to give a few words.
Yeah. Thank you, Nainika. You are young and the way you are getting shaped by Sejal, I see that and I appreciate the hard work. First of all, thank you, Sejal. Thank you for giving me an opportunity to be co-host with another legend here, Dr. PG Paul. And it's always great to see him, hear him, and just he be around us. I can imagine Dr. Paul with the pleasant personalities coming and help guiding you for this abnormal uterine bleeding webinar. Sejal, what I see is, any task you take in, it's not that I'm supporting because you are our fellows or you are our bacha. The FOGSI and as an organization needs the dedicated leaders. We do have many chairpersons today or in the past who are on the chair and doing no work much. And unfortunately, FOGSI gets stuck with those chairperson for 3 years. So we always like to have the chairperson who wants to work for the organization. So in an endoscopy committee, we have witnessed in last 8-10 years, so many amazing conferences you have organized, so many IAG projects or the FOGSI projects, you have taken time out, not only led the project, but you ensured that those projects have been widely implemented. So definitely, when you wish to come for the endoscopy committee of FOGSI, I think the FOGSI will get benefited hugely. The work Dr. Subhash Malya has done, I have closely observed Subhash Malya in last 3 years, and he has really taken this endoscopy committee to a different level. He traveled himself doing conferences or the projects in a smaller BNC societies. And if you join or follow the path of his, absolutely it will be like endoscopy हर घर में. जो नरेंद्र मोदी बोलते हैं ना घर घर तिरंगा, वैसे हर फॉक्सियन के घर घर एंडोस्कोपी हो जाएगी. So it's really, I wish you all the best. And I see the efforts you are putting in to connect with various societies. Today you involved Ahmedabad Society, Dr. Sunil Shah. Everyone knows him in FOGSI, and Dr. Akshay Shah. From Aurangabad Society, Dr. Lalita Bajaj and Dr. Bhagyashri Sudhir. From Nashik Society, Dr. Sangeeta Wagh and Dr. Anjali Kulkarni. And Navsari Society, Dr. Narendra Gajjar and Satyan Kasabwala. I hope Satyan is very good, in very good shape. He is a great endoscopic surgeon, shaped up and guided by Dr. PG Paul, and Dr. Narendra Gujjar helped me a lot in my FOGSI presidency election. So when you have selected all these 4 societies and a great speakers, so that you will make this AUB a very good webinar. So I'm delighted, I'm happy, and I wish you all the best. And I'm sure I will be enjoying this webinar with you all. Thank you.
Thank you
Thank
so
you.
much, madam. Thank you. You're always, you are motivating always, and you are picking up all small efforts what we are doing. You are noticing that, and that really touch our heart, madam.
Thank
Nothing can miss from your eyes, madam.
Sejal, you are a very honest, dedicated worker. Keep this honesty and purity for a long. Thank you.
Thank you, ma'am. Thank you, ma'am.
Thank you,
Thank you.
Sunita madam, for your kind words. Now I would like to invite Dr. PG Paul sir to give his inputs and encouragement.
My dear friend Sunita, my classmate Jagruti, my fellow Sejal, all faculties, and my dear friends. Actually, I liked this topic which Sejal said, because I was just recollecting the AUB is the main breadwinner for all gynecologists. 40% of our patients are for AUB. And I was just finding out what all things changed in my practice about AUB. The first thing, I still remember our topic of DUB for our PG exams. I never liked that term DUB. I never understood what is this dysfunctional and all. Now, FIGO has come with a very wonderful the palm coin classification and the definition. They changed from menometrorrhagia and so many things. And I think that is one remarkable thing that happened to AUB management. The second thing was the role of ultrasound and hysteroscopy. I think hysteroscopy has saved a lot of uterus because we never diagnosed a submucous myoma properly before actually going into surgery. A lot of uterus have been really served by hysteroscopy. And the next simple medication I found liked was this tranexamic acid, mefenamic acid combination. And all patients can take, a lot of patients with the simple medication can manage many of the menorrhagia. These are the few observations I looked at when what happened to the AUB management and the diagnosis the last maybe 40 years of my practice. And Sejal has done a lot of work, and all credit goes to Sunita for making Sejal such a wonderful person. Sejal has such a phenomenal work for IAGE, and now she wants to take up for FOGSI. I know there are many candidates who are equally competent, but Sejal is someone who is totally different, who take up something, then she never stops till she finds the ultimate of that particular task she takes. So Sejal, all the best for your FOGSI stepping stone.
Thank
Thank
you. Thank you so much, sir. I am so obliged today. I am having both of my gurus here, sitting here. So I can't express my feelings over with words, but I will definitely, my thing is to follow your advices from the day one. And I am just trying to reach up to your standard, up to both of your expectations. That's all. Thank you.
you, Sejal.
Thank you. Thank you.
Thank you, dear.
Thank you, Paul sir, for your kind words and encouragement. Now we have Dr. Sneha Bhuyar with us. Madam, Dr. Sneha, madam, are you there?
I did not see Sneha. It's unlikely that Sneha don't join. Probably she cannot have, got internet connection. It's raining very heavily in Maharashtra.
We are having a heat wave
Ma'am,
in Rajasthan.
I have tried to call her, madam. Must be busy somewhere. We'll
You
try.
can
I
go
can't
ahead
see.
with your academic program. I see Dr. Geeta Khanna here. I see Jagruti Desai, Lalita Bajaj. I see Anuradha Shevale. You have the real, dynamics with you. Please go ahead with your academics.
Thank you. Thank you.
Sejal, madam, should we start with
Yeah,
the session in the
We'll start, and whenever Sneha madam join, we'll introduce her that time.
Great, okay. Dr. Mohan, could you please take from here?
Yeah. So good evening for everyone. I would like to invite Dr. Lalita Bajaj for giving a talk on abnormal uterine bleeding and focus on the medical management of abnormal uterine bleeding. The chairpersons are Dr. Bhagyashri ma'am. She is the secretary of Aurangabad Aurangabad Society and honorable treasurer of AOGS 2019 to 2024 and managing committee member of Aurangabad Society of 2018 and 19. She is honorable treasurer also in a national conference of OBGY 2019, contributed as a author of chapter on intra-iliac artery ligation, and she's presented a paper in many state conference and the national conference also. And our second Sunil Shah sir is here. Sir, good evening. Sir has done his MD and FICOG and FBBS infertility specialist trained at Germany. Sir is recently president of the Ahmedabad Obstetrics and Gynecology Society. He is a joint secretary of FOGSI in 2020 and written many chapters of male and female infertility. Sir has a vast experience of infertility and received a prestigious Gujarat Shastri Award by the Honorable Chief Minister of Vijay Rupani, sir. Latika ma'am, can we start?
Yes, yes.
Yes, stage is up to you, ma'am.
Yes. I need slideshow. You will show
yes,
it.
ma'am,
Yeah.
Yes, ma'am.
Please. My presentation.
This is
Nanika,
your
I have sent the slide share.
Please introduce
Yeah,
Lalita madam.
I would like to introduce Dr. Lalita Bajaj, madam, who is our first speaker.
Yeah.
Madam has done her MBBS and DGO, and she has had a vast experience in working in multiple government hospitals. And now she has her own private hospital since 1999 till date. Madam has been the president at AOGS and secretary at OB and at Aurangabad Society as well. And she has held many posts in the offices of FOGSI. And her area of interest is high-risk obstetrics. We welcome you, madam, for your presentation today.
Thank you. Thank you very much for kind words. At onset, I want to thank you, Dr. Sejal Naik, madam, who has given me the opportunity, and the organizer whole team who has given me the opportunity to talk on my favorite topic. abnormal uterine bleeding. So please, medical management of abnormal uterine bleeding. Can it be done slideshow?
Yes,
from
we'll
your
do.
side,
Nainika, please change this slide.
Madam,
Stop this screen
Ma'am,
share.
I have
You
I
can
have
able
sent
to
you the
stop this.
presentation, Anika.
Yeah, now
Yeah,
I
you
will
have
share. Yeah. Is my screen visible?
Yes,
Yes.
yes.
Make
Yes,
it
yes, that's on.
slideshow.
Yeah.
Yeah, I'll do that.
Yeah.
Next. Abnormal uterine bleeding, focus on medical management. What is abnormal uterine bleeding? Before we should know that. Any variation from the normal menstrual cycle includes changes in the regularity and frequency of menses, in duration of flow, or in amount of the blood loss. That is abnormal uterine bleeding. Next. Abnormal uterine bleeding can be acute or chronic. Acute, an episode of the bleeding in a woman of reproductive age who is not pregnant that is sufficient to quantity require immediate intervention to prevent the further blood loss. And chronic, the chronic AOB that is abnormal in duration, volume, and or frequency and has been present for most of the last 6 months. Next. FIGO classification for nomenclature for the abnormal uterine bleeding is heavy menstrual bleeding or intermenstrual bleeding. That can be PALM's classification, that is structural causes, and Cohen's classification, that is the non-structural causes. In structural causes, polyp, adenomyosis, leiomyomas, submucous myomas, other myomas, malignancy, or hyperplasia. In Cohen's classification, non-structural, the causes can be coagulopathy, ovulatory dysfunction, endometrial or iatrogenic, and not yet classified. So before we go for the treatment, we should know basic about the abnormal uterine bleeding. That's why we have started with this. Next. This is the only diagrammatic presentation of the FICO classification, polyp, adenomyosis, malignancy, that already I have told you. Next. The AUB subsets in the perimenopause, that it could be ovulatory or anovulatory AUB. Ovulatory AUB, ovulatory bleeding may be heavy and can be associated with the typical premenstrual symptoms and painful period. Anovulatory AUB, found more frequently during the perimenopause, is often linked to the prolonged period, heavier flow, and an irregular cycle. If prolonged, example PCOS, or associated with the obesity, anovulatory bleeding has a stronger link to endometrial cancer and endometrial hyperplasia. Next. AUB menstrual bleeding pattern, that can be the disturbance in the rhythm, duration, amount of the flow. Menorrhagia, where heavy bleeding is seen. Metrorrhagia, bleeding is between the period. Polymenorrhea, interval of the bleeding is less than 21 days. Oligomenorrhea, interval is more than 35 days. Next. Etiology, the hormonal changes can give rise to AUB. Benign anatomic changes like uterine polyp, uterine fibroid, adenomyosis, low thyroid function, other medical conditions like coagulopathy or cancer, that might be primarily endometrial carcinoma, but cervical cancer can also give rise to perimenopausal AUB. Next. Hormonal imbalance and AUB, unopposed action of the estrogen that causes the disturbed angiogenesis and altered blood supply, and that lead to large thin walled tortuous superficial endometrial vessels can often be demonstrated on the surface of the and hyperendometrium and increases the fragility. That gives rise to DUB, increased blood flow and clotting. Next. So for diagnosis, we must know the history, physical examination. From history, menstrual cycle history, we have to take AUB bleeding pattern, how it is. Is there any history of medication taken, warfarin, heparin, NSAID, or OC pills like that? And on physical examination, PCOD can be diagnosed with the obesity, hirsutism, or acne. It needs further investigation, but that can be diagnosed on the physical examination also. Then thyroid dysfunction, cold, heat intolerance, dry skin, lethargy or proptosis. In diabetes mellitus also, there can be acanthosis nigricans, bleeding disorder like patches, pallor, or signs of hypovolemia. Or on pelvic examination also, we can diagnose the bleeding. Next. Diagnosis from the lab, like pregnancy test has to be done to rule out the pregnancy. Then CBC, targeted screening for the bleeding disorder when it is indicated. Thyroid, TSH, gonorrhea or chlamydia in high-risk patient. Then imaging can be transvaginal sonography or sonohistography, hysteroscopy, MRI or endometrial biopsy. This can help us for the DUB diagnosis. Next. Then once we diagnose the common differentiation, because management depends on the age of the patient also. From 13 to 18, there could be anovulation or OC pills, oral contraceptive pills, pelvic inflammation, coagulopathy or tumor. From 19 to 39 years, pregnancy or structural lesion like leiomyoma, polyp, anovulatory cycles like PCOS or OC pills taken irregularly, endometrial hyperplasia, endometrial carcinoma is less common, but in case age of 40 or menopause year, age, anovulatory bleeding, endometrial hyperplasia carcinoma or endometrial atrophy, leiomyoma, these could be the causes for the AUB. So management depends on the cause diagnosis. So next, then the management, medical management should be initial treatment for most of the patient. Need for the surgery is based on the various factors like stability of the patient, severity of the bleed, contraindication to the medical management or underlying cause. Type of the surgery also depend on above and desired for the future fertility. Long-term maintenance therapy after the acute bleed is controlled, we can continue with the. First, we need to control the acute bleeding. Determine acute or chronic. If acute, signs of hypovolemia or hemodynamic instability, then IV has to be started, 1 or 2 large bore needle. Prepare for the transfusion. Clotting factor should be given if needed. Once the patient is stable, evaluate etiology according to the palm or coins classification and then determine the treatment. Next. Before selecting the best treatment for the consider the patient's following. Treat patient with the dignity and respect, need for the current or the future fertility if it is there, facilitate informed decision making of the woman seeking treatment, allow the woman to choose the treatment most appropriate for her. Next. In medical treatment, there are 5 forms. Hormone treatment. In hormone, estrogen, progesterone, combined OC pills can be given, progestagens only, or LNG, IUCD, GnRH analogs, estrogen only. PRM, ulipristal acetate is also helpful. SERAM serums, ormiflexon can be given. Antifibrinolytic agent like tranexamic acid, NSAID in mefenamic acid can be tried. Radiotherapy in case of malignancy, which is very rarely required. Next. We'll see in detail about every non-steroid anti-inflammatory. Ideal NSAID would be the selective inhibitor of vasodilatation, prostaglandin permitting in vasoconstriction, PGs, to inhibit the excessive menstrual blood loss. But such selective inhibitor is not yet available. So NSAID reduce blood loss by about 25 to 30% in all women. Commonly used are mefenamic acid and naproxen. NSAID have shown only minimal effect in anovulatory menorrhagia, but side effect include like minimum side effect, gastrointestinal disturbance or headache. Next. Tranexamic acid reduces blood flow by 50%. However, many women remain menorrhagic and may are non-compliant due to the daily doses. Only if patient doesn't take the doses, then only they are non-compliant, so menorrhagia may remain. Large doses of tranexamic acid are required. Incidence of GI side effect and intermenstrual bleeding are relatively high. Risk of the thromboembolic disorder is concerned with this tranexamic acid. This is a comparative study. Next. LNG IUCD, this is the best and in today's year. It depends on the age of the patient. The progesterone releasing intrauterine device is an effective treatment for menorrhagia. Its main advantage are relief of dysmenorrhea, effective contraception, and long-term control of the menorrhagia following insertion. The main disadvantage, they are very minimum, like intermenstrual bleeding, breast tenderness, and that are also in very few time for few months. Contraindicated are the pregnancy, unexplained vaginal bleeding, and uterine sepsis. But LNG is the really very good for the DUB in perimenopausal women. Next. GnRH agonist Utility should really be for the short-term use, particularly useful in the treatment of leiomyoma, which can reduce considerably in size when ovarian hormone levels are suppressed, may be used prior to the surgical intervention in the woman with fibroid or for those in whom surgery is not suitable, desirable. Studies have demonstrated excellent effects with the amenorrhea rate up to 90% with GnRH agonist use. Danazol is not frequently used because of its androgenic and long-term lipid profile side effect. Next. Oral contraceptive action is probably mediated through the endometrial atrophy. OCP suppresses the pituitary gonadotropin release and thus inhibits the ovulation. High doses of estrogen are associated with increased risk of the thromboembolism. This should be avoided in the woman with the thrombosis or the family history of idiopathic venous thrombosis. Most common side effects include the weight gain, abdominal disturbance, mid-cycle breakthrough bleeding, and these are not suitable during pregnancy. The patient who require the desiring pregnancy. Injectable progesterone, medroxyprogesterone acetate, %80 after 5 years. This is also very good. Injections are usually given every 12 weeks to maintain progesterone exposure and ensure the contraceptive effect. Side effect can limit compliance and include weight gain, greasy hair, and acne and bloating. Injectable is also very good for progestin therapy. Most commonly used hormone therapy during the luteal phase. Norethistone is most commonly used oral progestogens in the treatment of heavy menstrual bleeding. Older women with the hypertension or the diabetes who smoke are not good candidates, but progestins modulate the effect of estrogen on target cells and metabolizes the estrogen, and the endometrium is maintained in a state of antimitosis. So mitosis doesn't happen and growth is not there. Next, hormone therapy and non-hormone therapy. The non-hormonal treatment is effective mainly in the setting of the heavy menstrual bleeding when the timing of the bleeding is predictable. Irregular or prolonged bleeding is most effectively treated with the hormone options that regulate cycle, decreasing the likelihood of the unscheduled and potentially heavy bleeding episodes. Next. Consideration of medication therapy. A recent study showed that 38% of the women less than 40 years of the age have unsupported pathology at the time of the hysterectomy performed for AUB, uterine fibroid, endometriosis, or pelvic pain. In addition, overall, up to 38% of the women who underwent to the hysterectomy were never offered an alternative options. Therefore, it is crucial to review the medical option available and to reduce the reliance of major surgical intervention like hysterectomy. Consideration of the medication therapy. Classification. Next, madam. Next. Full slide should be shown so that I can read out. Classification of progestogen therapy. These could be related to progesterone, related to testosterone, or related to spironolactone, like drospirenol. Next. Classification of exogenous progesterone, natural progesterone, or synthetic progesterone. That can be 19-nor progesterone, 17-alpha hydroxyprogesterone, or 19-nor testosterone. 17 hydroxyprogesterone derivatives have susceptibility of 17 that show hepatic metabolism. 19 non-testosterone derivatives display primary progesterone rather than androgenic activity norethistone. So replacement of 17 hydroxyprogesterone, norethistone with and 17 suitable are more potent progestins and less androgenic. These are norgestrel and nongestrel. Next, we'll talk about the progestogens now today. Norethisterone. Norethisterone is a molecule used to some combined oral contraceptive pill, progestins, only pills, and is available as a standalone drug also. Used to treat PMS, painful period, AUB, and irregular periods, menopausal syndromes is in combination with the estrogen or to postpone the period. It is also commonly used to help prevent the uterine hemorrhage in complicated non-surgical or pre-surgical gynecological cases. Next, norethisterone is really helpful Norethistron acetate is an acetic acid ester. Therapeutic uses of norethistron have long-standing and widely accepted, and it requires less frequent dosing. Dose is 2.5 to 10 milligram for treatment of AUB. Next. Mechanism of action is that it reduces mitotic activity, decreases the growth of endometrium, and prevent or reversal of the hyperplastic disease process in the endometrium. Next. Next, clinical evidence of NETA. So, norethistron acetate versus combined OC pills in puberty menorrhagia. So, norethistron acetate was more effective and better tolerated compared to the COC in puberty menorrhagia. Next. NETA versus drospirenone or ethinyl estradiol. Both drugs were effective in suppressing dysmenorrhea. A continuous NETA regime is well tolerated, effective, and inexpensive option for the dysmenorrhea treatment and was as good as COCs. Next. Efficacy of NETA as compared to medroxyprogesterone acetate in treatment of perimenopausal DUB. Norethistron was more effective than the medroxyprogesterone acetate in controlling irregular vaginal bleeding. Treatment with the NETA significantly improved the quality of the life of the patient. Next. Next, madam. The guideline for recommended for the NETA ACOG guidelines in 2013 for the control of the acute bleeding, NETA 5 mg should be considered 3 times daily for 1 week. European consensus group in 2011, NETA 5 mg to 10 mg should be given every 4 hours until the bleeding stops. And NICE guidelines, they say NETA can be given 15 mg, which should stop the bleeding within 48 hours. And severe cases, 30 mg can also be given, but we don't do this much. Next. Next, madam. To summarize, yes. Yeah. To summarize, summary of medical treatment of the abnormal uterine bleeding, combined contraceptive pills, they reduces the menstrual regular. They have the menstrual regularities with the combined OC pills create menstrual regularity. It reduces 20 to 50% reduction in the menstrual blood loss and reduction in dysmenorrhea. LNG IUCD, they reduces blood flow by 70 to 97% reduction in the menstrual blood loss, amenorrhea in up to 80% at 1 year and reduce dysmenorrhea. Cyclical oral progestogens, they also reduces the bleeding up to 87% with the long phase regime. Injectable progesterone, 60% amenorrhea at the end of 12 months, and they can create 68% at 24 months. Dinazole 100 to 400 milligram is given. 80% there is a reduction in the menstrual blood loss, 20% amenorrhea is, and 70% there is oligomenorrhea. GnRH agonist like lupride acetate, bleeding is stopped in 89% by 3 weeks to 4 weeks. NSAID, about 20% to 50% reduction in the menstrual blood loss, and dysmenorrhea is reduced to 70%. Antifibrinolytic agent like tranexamic acid, 40 to 60% reduction in the menstrual blood loss. Next. So to take home message is abnormal uterine bleeding is a significant debilitating clinical condition with the prevalence of around 18% in India. Hormonal management is considered to be the first line of management therapy for patients with the AUB. Norethistron acetate has obvious curative effect on the effective reduction in the menstrual blood loss. NETA is generally well tolerated with minimum side effects, and it reduces menstrual blood loss, mean menstrual blood loss by 87%. NETA is equally or more effective in the treatment of AUB as compared to medroxyprogesterone acetate. So according to the age, in puberty age group, OC pills and progesterone is more effective. In perimenopausal group, LNG, they are more helpful. So LNG and progesterone is like a Sanjeevani for a DUB patient for the medical management. Like misoprostol is very good in obstetric. In the same way, progesterone is very good for the gynec patient. Thank you. Thank you very much.
Thank you so much, Lalita Bajaj, madam, for lighten up our knowledge regarding the medical management of abnormal uterine bleeding. Now, I would like to say concluding remark to our chairpersons. So say a few words regarding concluding remarks and all. Dr. Bhagyashri ma'am and Dr. Sunil Shah sir.
Excellent talk by Dr. Lalita ma'am. Ma'am has covered almost all points. I want to add only one point. Means various studies depicted that aromatase inhibitors. We can add aromatase inhibitors along with progestins or oral contraceptive pills. It reduces the pain, means it reduces the intensity of pain due to endometriosis and adenomyosis and improve the quality of life. So thank you, Dr. Lalita ma'am.
Thank you
for
very
excellent
much.
talk. And I am also thankful to organizers and Dr. Sejal ma'am for giving me this opportunity. Thank you.
Thank you, madam. Sunil sir is here.
Yes, Sunil sir.
Sunil sir was here till now. Yeah, Sunil sir is there.
No, I'm searching that ma'am.
Okay. So thank you so much, Lalita ma'am. So we are honored to have you here today. And it was
Thank you
very
very
crisp
much.
and clear carry on messages with the medical management of abnormal uterine bleeding.
Ma'am, I would like to say one thing that one of the good company has made a combination of estradiol valerate with dinogest. 28 tablets is there from day 1 to 28 days you have to give. It will reduce the 70% of abnormal of uterine bleeding after the second menses. It is a very good product.
Yes.
Sejal ma'am, can I add something?
Yes, please, madam. Please.
Yeah. Yes, ma'am.
Welcome, madam. Anuradha ma'am.
Very good talk by Lalita.
Thank you, madam.
I want to add, day by day, we are facing more polycystic ovarian disease patients, young girls. And there we always have dilemmas because the age of menarche is reducing. So there we cannot use OC pills for long time. We can give for short time because if we give estrogen for long time, there the total growth of the patient or the height of the patient will be affected. So in those patients, we try to give norethistron tablets, as Lalita was telling, and she was insisting on it. But norethistron also has a lot of problems. Like those patients already, they have acne and hirsutism.
Ma'am, you are muted, ma'am.
So
Yes.
what do you think?
Yes.
Long term, we can't use that. That is what I want to say.
Ovulation induction, after that, ovulation induction can be done for PCOD patient, young girls, 25 years also.
No, pubertal girls. Like
Okay, yeah.
So in those patients that we can do OC pills continuous, but only for 3 months, 4 months. After that, we have to stop and switch over to the progesterone. Then we have some other progesterone also. If the patient is already hirsute and she has acne, then this norethistron may add to it. So there, progesterone acetate is a better choice. What I feel in those patients where we have acne and hirsutism. Okay.
Thank you. Thank you, madam. Thank you.
Thank you, ma'am. Now, I would like to...
Bhagyashri ma'am, Sunil sir, thank you so much.
Thank you, ma'am.
Now, I would like to invite Dr. Sejal Naik, ma'am. She is a dynamic speaker and she is a renowned laparoscopic surgeon. She is a national coordinator for Endoscopy Committee, FOGSI, and she's been giving a topic of surgical management of abnormal uterine bleeding. And our chairperson for this topic is Dr. Sangeeta ma'am, and she is the president of the Nashik Society, and Dr. Jagruti Desai ma'am, she is the past president of the Surat. Ma'am, stage is up to you.
Yeah. 1 second, I'm trying to share my screen.
Yes, ma'am.
So welcome everyone, and I'm very grateful to FOGSI Endoscopy Committee and the entire FOGSI, Dr. Jaideep Tank sir, President, Dr. Madhuri Patel ma'am, Dr. Janmejaya Mahapatra sir as a Vice President, and especially Dr. Subhash Malia, Chairperson of FOGSI Endoscopy Committee, for giving me this freedom to have these FOGSI Endoscopy Committee webinars. And thank you all the FOGSI societies, Ahmedabad Society, Aurangabad Society, Nashik Society, and my neighbor near sister society, Navsari Society, to collaborate and to motivate us to go ahead with the academics on this virtual platform. I am really thankful to all speakers, Lalita madam, Gajjar sir, and the panelists for taking out that time for these academic inputs. And I'm really grateful all chairpersons for being here on this very auspicious day of Akshay Tritiya and giving their valuable inputs into these academics program. And none other than my both gurus, Dr. Sunita madam and Sanjay Patel, sorry, Paul sir, to be here. And we are still waiting for the Sneha madam to join. She may join in few minutes. So without wasting much time, am I? One second, I'm unable to share the screen.
Shrenik bhai.
Madam is a co-host already.
Second. I can't find out that my PPT slide on share the screen.
Ma'am, if you have it in a phone, then send it to one of us. We can share it for
Yes,
you.
ma'am.
Yes, because but it has videos, no? So one second, I'll once up again close and open that. Am I co-host here, no?
Yes, madam.
Now, can you see? Can you see now?
Yes, ma'am.
Yes,
Oh.
yes.
Yeah, thank you.
Absolutely.
I thought it will be. So I'm sharing this. So I'm going to discuss about the surgical management of Mohil, you need to unpin yourself. One second. Okay. So today I'm going to discuss about the surgical management of abnormal uterine bleeding. Lalita madam has very nicely elaborately mentioned the medical management. When will be the role of surgical management in abnormal uterine bleeding? So there is a need of surgical management based on the clinical stability of the patients, and it's the severity of the bleeding. You can't wait to drugs to act if there is a torrential bleeding. So any contraindications for this medical management, and if the medical management fail or the patient's medical conditions underlying that only permits her for the surgical options. So what are the surgical options? There can be a simple, and the commonest one is the DNC, endometrial ablation techniques, the uterine artery embolization, hysterectomy, and the other hysteroscopic and laparoscopic procedure depending upon its cause. The choice of surgical modality is based on the aforementioned factors plus the patient's choice for future fertility also. So one has to consider the other clinical factors, patient's age, and her desire for the future fertility. And the ultimate goal is to reduce the blood loss and to maintain the hemoglobin level that can lead to her the healthy life. So before proceeding to any surgical modality, as Paul sir already mentioned, that the good quality of ultrasound is most important here to diagnose the actually if any causative factors. Here the role of 3D ultrasound is also important, where there is a, why these slides are running automatically. So here there is also role of 3D ultrasound, where we can diagnose the intrauterine pathologies and the Mullerian abnormalities or the submucous fibroids. They are compressing the cavity, which can be missed in 2D ultrasound. So ultrasound by the surgeon is one of the most important before proceeding to any procedure. Now, dilatation and curettage is one of the most common procedure and the most junior one is started doing. It is the majority of us has done this is as of our first gynec procedure. So it is very easy. The procedure is just a dilatation of the cervix and the endometrium is to be scraped away. It is mainly used in cases where there is a diagnostic purposes, when the endometrial polyps or fibroids or that is malignancy is suspected. To get the histopathological sampling. A study of 366 women evaluated that the findings obtained from the hysteroscopically detected biopsies versus the pathology results of the tissue obtained by the DNC. They concluded that both procedures has a concordance results of around 88%. So they are compatible to each other. So DNC has still its own role. But hysteroscopy can give us a direct visualization, and direct visualization, directed biopsies are much more accurate. But it also means sometimes we miss the hyperplasia and certain malignancy if the tissue is not taken from the particular place. So global endometrial sampling has been recommended to the many of the studies. So DNC, however, it's contraindicated when the pregnancy is there, intrauterine pregnancy with the maybe the patient desire to continue the pregnancy. And if one is unable to visualize the os and there is obstructed vagina, one may not be performed DNC. And the major complications of the DNC is the bleeding and hemorrhage, followed by that cervical lacerations or trauma, perforation, false passage, and the post-procedure infection that may lead to intrauterine synechia or adhesion. And the procedure is majority of the time done in under anesthesia. So the anesthesia related complications. So the DNC usually has a limited role for a duration 3 to 6 months only. So for a longer duration of the cure, there are other modalities like endometrial ablations. Now, this ablation is the alternative to hysterectomy, where we can save many uterus and the cost is the limiting factor. The principle remains here is to damage the basal underlying the functional basal endometrium. So thus preventing its cyclical endometrial regeneration or suppressing the menstruation, thereby inducing the amenorrhea. These procedures are less effective in women under age of 35, where there is a pain is significantly associated symptom with abnormal uterine bleeding, and when the uterus is enlarged due to the adenomyosis also. And it is contraindicated when the patient is desired for future fertility. So these are the first generation procedures of ablation, that is the laser ablation or transcervical resection of the endometrium hysteroscopically or the roller ball. It is to be done post-menstrual so that the lining is already very thin. Pre-treatment oral contraceptive pills can thin out the endometrium much more and easy to remove the basal layer. The pre-treatment danazol or GnRH agonist can also be given and can increase the chances of amenorrhea. And these techniques are effective. They are very minimally invasive and they are a good alternative to hysterectomy. It requires a significant operative skill, though, and the indoor facility and the anesthesia facility. So, such a procedure can save many uterus. And suppose patient is 35, family completed, and she is not the candidate for hysterectomy at this age, having the hyperplasia and menorrhagia related to the ovulatory issues or maybe the endometrial issues. So this can be dealt better with the this kind of ablasive techniques. And usually they produce is a very reduced amount of blood loss or maybe the amenorrhea following the procedure. The second generation techniques are the thermal balloon ablation or the microwave endometrial ablation. There may be a hydrothermal ablation, bipolar radio frequency ablation, and the endometrial cryotherapy can also be tried without the need of this, can be done without the need of hysteroscopy, and it can be the outpatient procedure and thus maybe the cost effective compared to this TCRE. So what are the indications for this ablasive technique? Already been mentioned. It has to be the benign origin abnormal uterine bleeding, and it can be considered as a primary intervention in circumstances where there is an intolerance or the failure of the medical therapy, or it is the patient's preference. They don't want to be on pills so many years. So this can be the patient's preference. And this may be the consider for the patients who refuses or are the poor candidate for the surgical management like hysterectomy. So absolute contraindication is the pregnancy, those who want to preserve the uterus, having a known case of malignancy or suspected malignancy. And then there may be specific contraindication related to active infection like that. So how effective are these ablation technique? The satisfaction rate is nearly 77 to 96% following the ablasive technique, and amenorrhea is occur in like 15 to 70% of the women. The quality of life is substantially improved to a normal level after 12 months of the treatment with either first or second generation ablation techniques, and which is very quite a high. The failure rates after the ablations have been reported between 5 to 16%, and these patients may require a second sitting of the ablation or can be counseled for further for the hysterectomy. So another modality of minimal invasive is the uterine artery embolization. It is a safe and effective technique now with the latest advancement in the therapeutic radiology. The selective embolization of one or both uterine artery in order to suppress the uterine bleeding, to avoid surgical intervention, and to conserve the fertile future of young women. Still, there's some data are required for the future fertility, but it is thought to be this can be used for the couple who have who are wishing for future fertility, but we are doing at least those who have only at least one living issue. So we only recommending them for the uterine artery embolization for the moment right now. This technique has proved a high rate of success, especially when there is a arteriovenous malformation or there is a bleeding related to neoplasm or the uterine fibroids. So hysterectomy is the, like, it is a definite treatment. Na rahega baans, na rahegi, na bachegi bansuri. But this is for those who don't want future conception, but this is not for everyone, those who have completed the family. So one has to be very judicious advising about the hysterectomy. It's an end treatment for all abnormal uterine bleeding. It is indicated with when there is a medical like fibroids or prolapse. It is associated with endometriosis, adenomyosis, etc. Only when the appropriate drugs or simpler procedures like LNG IUD or other things are ineffective or inappropriate or they are failed. So conservative surgical procedures such as endometrial resection, ablation, myomectomy, or whatever the causative factor, that has to be given as a priority option for the patient, and patient should be properly counseled. But do not pull on the patients with the hemoglobin 4 and 5 and 6 and avoiding the hysterectomy if she's not responding to anything and she's not a candidate for any other surgery, because ultimate the quality of life is most important. So hematocrit abnormality, in spite of all conservative effort, one may think about the definite treatment is the hysterectomy. Hysterectomy, as we all know, abdominal hysterectomy, it is one of the most common surgery performed, and it is associated with a greater morbidity because of the incision and the woundation, pain, hemorrhage, infection, that we are comparing with the vaginal hysterectomy and the laparoscopic hysterectomy. And overall complication rates of this is around 25%, 43%, while the vaginal hysterectomy may be the 25%. Vaginal hysterectomy is truly a scarless procedure and is associated with the low morbidity and shorter hospital stay. And as we all know, TLH, there is no debate between abdominal hysterectomy and the laparoscopic hysterectomy. So laparoscopic has proven its role long way back, maybe the decade or maybe 2 decades back. So it is really minimal invasive, it's a bloodless, painless, and the faster recovery. So for the patient can resume the job within 2 days following the surgery. Other causes of the abnormal uterine bleeding is the polyp. So polyp prevalence is around 7.8 to 35% of the patients, and it is usually visualized in ultrasound in follicular phase with echogenic mass in between the trilaminar endometrium. And it's an excellent response to the post procedure. There is a drastic reduction in the blood volume and the like total blood loss. So can be done easily with the outpatient procedure. The polypal pedicle can be excised with the scissors, or if such a large polyp is there, can be excised, making it into the small pieces with the resectoscope or with the scissors. Do not cut at the base, because then the removal of the entire big specimen through the internal os would be very difficult. So though the emptying, you make it in a small pieces so that the pieces can be removed easily from the uterine cavity, and this can be sent for the histopathological examination. Another reason of these abnormal bleeding is that any foreign body inside can be like lost intrauterine devices, or like forgotten devices. 10 years back the IUD was inserted and the patient forgot completely, and can be associated with other pathology intrauterine. Better to put the hysteroscope, have a visualization of the entire cavity, confirm your diagnosis, and then if the thread is not visible or you cannot remove it under ultrasound guided, one can remove it with the hysteroscope. That is, you can pull the vertical arm with the polypectomy forceps and pull it out entirely with the assembly or hysteroscopic assembly. Another indication of this surgical management is the leiomyoma. So these fibroids are one of the most common benign tumors of the reproductive age group. Especially, it is estimated to that 20 to 30% of the reproductive age women are affected with the fibroid. Here, not all fibroid are causative of her menstrual problem, but certain fibroid of that are compressing the cavity. You can see on 3D ultrasound that whether it is submucosal type FIGO classification 0, 1, 2, 3. Sometimes they are just touching the endometrium, and you may not see on the routine hysteroscopy, but you have to reduce the pressure to see that there is a bulge inside. So on increasing the pressure, you will see there is no bulge and there is absolute normal cavity. But on reduction of the intrauterine pressure, you can see this kind of fibroid may cause her for the abnormal uterine bleeding or entirely submucosal fibroid. This is the type 3 fibroid. You have to see if the myomectomy is easier laparoscopically or the hysteroscopically, where the bulging is high. More you can perform, you can choose that route for the easy, simple surgery. So here what we did, the demarcation of the myoma location under low pressure with the cold loop, and then with increasing pressure, we activated the loop. We try to resect at the point going deeper. Once we see the shining white tissue, that is the submucosal fibroid, and then you can just keep on resect it with the under vision. Here we can use the bipolar resectoscope or the with the normal saline, which is having the good safety margin compared to the glycine. Because this kind of such a deep-seated myoma can have the larger blood vessels and can cause the volume overload very early or faster than what is expected or estimated. Where at the capsule, you can just scoop it. You don't use the current, you just scoop with this your loop and scoop it, try to scoop it out. In between, you reduce the pressure and increase the intrauterine pressure. That kind of massage of the contractions of the myometrium will push the fibroid more inside the cavity, and that will make your surgery much more easy and can be managed with such a minimally invasive procedure. Patient can be discharged on same day or the next. This, you can see this how deep it is, a crater like thing. It was completely removed, and the hemostasis is achieved with the coagulating at the certain bleeder points. And it is seriously a rewarding surgery. And one uterus you save, the patient will bring 10 more patients for maybe for further such a kind of surgery, or maybe for the hysterectomy. Those are maybe the direct indicated patients for the hysterectomy. Another is the laparoscopic myomectomy. Now, subserosal fibroid or the intramural fibroid, which are not compressing the cavity or disturbing the cavity, may not be region for her abnormal bleeding. One has to see and confirm the reason, because after myomectomy, patient should relieve of her bleeding issues, right? So if it is combined with her perimenopausal symptoms, then one has to give her a simultaneous medical management like LNG IUD following the myomectomy. So this is the one bilobe fibroid, where one was the deep-seated fibroid over the other. So that deep one was causing her a bleeding and pain problem rather than the superficial one. And the closure here is important to this can preserve her future fertility also, and the proper approximation and the hemostasis is important to achieve. Now, the adenomyoma is also one of the common reason for the abnormal bleeding. This is because of the adenomyosis itself cause lot many inflammatory reactions and lot many vascular hypervascularizations and neovascularizations and many chemical reactions which causes her to bleed abnormally. So hysterectomy actually is the gold standard, but the age factor here, the younger the patient, if we do the hysterectomy at the young age, we all know later on the complications and the other healthy issues for the patient. So there are other few techniques for the endometrioma reduction apart from the medical management. As the diagnosis is always challenging for adenomyosis, because there is a variety of spectrum of the presentation. There may be hypervascularization, there may be translucency, or maybe shadowing, lines and the cyst formation or the calcifications. There's a different types of presentation. So usually either it is underdiagnosed, or majority of time if one learn to diagnose, then it may be usually overdiagnosed. So endometrial resection or ablation can be try in such a patients, or the myometrial electrocoagulation or the reduction of the myometrium and the tissue, or the bulk reduction surgery, adenomyomectomy, or the uterine artery embolization can be performed. Here is the classical case of cystic adenomyoma bulging inside the endometrial cavity, and we can remove this with the resectoscope and finding out it's a cystic adenomyoma. You can definitely see there's a chocolate color fluid coming through this kind of cyst. It is evidence of the direct invasion of such endometrial cells inside the myometrium, and can be easily removed with the resectoscope with along with you can simultaneously perform the TCRE or can put the LNG IUD inside. So can give the better result, because LNG IUD also in this kind of patients of adenomyosis have a little higher failure rate compared to any other indicated patients. Now, adenomyomectomy laparoscopically is per se is not so much rewarding surgery, and it's not the first line treatment for any adenomyoma, but it can definitely reduce the volume. We usually do not advocate for the abnormal uterine bleeding or for the pains reduction, especially if patient is very young and keen to retain her fertility and she's unable to bear her pain symptoms, then one may try, but it is mainly we do for the fertility issue, that is after the failure of all kind of medical managements for these patients. There can be a classical method of adenomyoma with the flap creation or the triple flap method, where there is a like deep cleavage and the deep clean removal of the all adenomyomatic tissue, followed by suturing flap. It's mute yourself, please. It can be either done with the like triple flap technique, and this is usually we try to avoid entering into the cavity, but many of the time it is so deep we may enter by accidental entry is possible. So where we suture endometrium and then the O-links. So main concern here after the adenomyomectomy is the future rupture during the pregnancy. So one has to be very careful in the documentation of the surgery, and the with the photographs if possible is most important here. So wherever she goes, she carries that with her and can be taken care well by the obstetrician during her future pregnancy. Now, abnormal uterine bleeding, for the malignancy, is nowadays increasing, because we have seen less than 7% of the women, they come with endometrial malignancy at the age of less than 45 years. So total hysterectomy, and the other gold standard of radical surgeries are the definite treatment. And there has been a role of the fertility preservation depending upon the staging of the malignancy. But hysteroscopy here is the very good tool to diagnose such a kind of malignant tissue here. You can see the calcification, you can see the polypoidal growth there, and the abnormal vascularity, which is a sure shot see and diagnose on the spot of the malignancy. So you can see pinhead vessels here, and the the fungating growth here, and the calcifications of the certain areas, and these are the clear cut signs of patients having malignancy. So I would like to conclude my talk with this. AUB is the most common gynecological disease, and its etiology is classified by Palm-Cohen system. And good 2D, 3D ultrasound helps to inaccurate diagnosis and early diagnosis. The best treatment for endometrial polyp is hysteroscopic resection, where possibilities can be performed on outpatient settings, and dilatation and curettage should be avoided, just limited to the diagnostic purpose. Uterine artery embolization can play a vital role, especially in AV malformation, until if the patient is poor candidate for surgery. The gold standard for the treatment of adenomas is hysterectomy, but total resection and removal of have a good results, as new minimally invasive techniques may be offered to young female or those who desire future fertility. Myomectomy for symptomatic and mostly submucosal myoma, which cause be removed by hysteroscopically. The limit is like 5 to 6 centimeter, but it depends upon your expertise. Conservative surgery in the management of endometrial pre-malignant lesion is quite limited, and the hysterectomy is the definite treatment we all know of abnormal uterine bleeding, and but it has to be reserved if anything else is not effective. And the vaginal or laparoscopic route is preferred over to the abdominal hysterectomy. So with all this, I would take this opportunity to request you all to help me and support me for this, my future endeavor in as a chairperson of FOGSI Endoscopy Committee. Thank you.
Thank you so much, Sejal ma'am, for giving such a wonderful talk, giving a good examples of thermal ablation and myomectomy and adenomyomectomy. Now, I would like to give the mic to Dr. Jagruti Desai ma'am or Sangeeta Wagh ma'am to conclude their remarks regarding this wonderful talk.
Yes, thank you so much. Thank you, Dr. Sejal, for giving this opportunity, first of all. And to be very frank, I know Dr. Sejal since her college days. She was a brilliant student then, and now we all can see she has turned out into a brilliant endoscopic surgeon. She is working for the managing committee, FOGSI, and now it is our responsibility to see that she becomes the chairperson of the FOGSI Endoscopy Committee.
Thank you, madam.
Yes, your talk was excellent. You described all the methods, surgical methods. The medical management was very well described by Dr. Lalita Bajaj, and the surgical management. Your topic, the topic you chose is a perfect topic, because nowadays we see that whenever a patient turns up with abnormal uterine bleeding, they are so much scared. The surgeon or a friend of them will just advise go for hysterectomy, and however we try to convince them, they are not convinced. But this topic is very important for us, all of us, that is we doctors, especially the junior doctors also. So go once again, go through all the surgical methods mentioned by Dr. Sejal. First of all, the diagnosis is very important with the help of transvaginal sonography, and then all the other offer her medical management, surgical management. There are various methods. So don't go for hysterectomy, because preservation of the uterus is very, very much important. Previously, at the age of 40 or 45, the women didn't used to become pregnant, but now many times we see so many couples, they have lost their child a 20-year or a 25-year, and even at the age of 45 and 50 years, they come for child, and IVF, with the help of IVF, they can conceive. So let's not all go for hysterectomy. It is not the only solution. Only in selected cases, Sejal has already described.
I haven't shown video of hysterectomy, madam.
Yes. So preservation of uterus is very vital. That is all the methods described. The surgical methods, the ablation, the myomectomy, the adenomyomectomy is very helpful for preservation of the uterus. So very well done, Sejal. Congratulations and my best wishes.
Thank you, madam. Thank you to honor us on this platform. We have Dr. Subhash Malia with us, FOGSI Endoscopy Committee Chairperson himself. Dr. Subhash, we saw you here.
Subhash sir.
Dr. Sangeeta ma'am is there. Dr. Sangeeta Wagh.
Ma'am have just texted us that she is somehow busy in the emergency.
Okay. So
I think
we
Subhash
have
sir is
Dr.
also
Praful sir also here, President Surat Obs and Gynec Society. Sir is in USA, still attending our program. Thank you, sir.
Hello, Sejal.
Sir, yes, thank you so much, sir. Sir, you can on your video if possible. Yeah, thank you, sir. And congratulations, sir is a proud parent of twins who just got
Dr. Parth Doshi.
Yeah, Parth and Samar.
Graduation ceremony is just over. Sir is the president of Surat Obs and Gynec Society.
Yes, Sejal, I joined because I saw your message yesterday and I thought of joining. It was a convenient time. You spoke very well and we wish you all the best. You are the pride of Surat Obstetric Gynec Society, who is working extremely hard for all these years, and you have really come up as a star in endoscopy.
Thank you, sir. All your blessings, sir. So Dr.
Okay.
Subhash is still here? Subhash? Okay.
He's seen, but maybe
Hmm. No problem. So we can thank you, madam, for chairing the session.
yeah, thank you.
Should we go to the next session?
Yes, please.
So our third session is a case-based discussion. And we have Dr. Narendra Gajjar with us, who will be moderating the session. I will first introduce sir and then the panelist. So Dr. Narendra Gajjar, sir has done his MD from BJ Medical College, Ahmedabad, and has received many prizes and awards for his academic achievements. He's a practicing gynecologist at Ahmedabad Hospital since the past 40 years and Akash Fertility Center at Navsari. He's also been, he has held many positions. He has held many positions as the organizing chairpersons and past presidents at various societies, and he is also headed as a professor and unit head of the DGO courses in the Civil Hospital Navsari. I would like to introduce the panelist for this session. We have with us Dr. Anjali Kulkarni. Madam has done her MRCOG, DGO, FCPS, has been a secretary of Nashik and Gyn Society, director of OB-GYN Women's Healthcare Center and Maternity Home. I welcome you, madam. Dr. Suresh Raute. Sir has been a professor and unit charge of MGM Medical College, Aurangabad, and he has been awarded as the Guru Gaurav Award by the Rotary Club in Aurangabad, and he has authored chapters in higher obstetric books and multiple presentations and publications to his name. I welcome Dr. Suresh, sir. Dr. Nikita Patel, madam has done her obstetrics and gynae, followed by minimal invasive surgery fellowship from Dr. Paul's, and has done her fellowship in reproductive medicine also, and she owns her hospital at Navsari called as Sri Jeevan Hospital. I welcome you, madam. Dr. Anuradha Chevalier, madam. Dr. Anuradha Chevalier, madam, has done her diploma in assisted reproduction university from Kiel. She's done a diploma in pelvic endoscopy, and she's the director of Chevalier Hospital and Ajanta Fertility Center in Aurangabad. She has been the president of Aurangabad OBGYN Society and FOGSI recognized Center for ART and Infertility. Dr. Anuradha, madam, I welcome you. Dr. Margi Shah has done her minimal invasive surgery fellowship from Dr. Paul Sirs and is an assistant professor at Sal Hospital, Ahmedabad. I welcome Dr. Margi Shah. Do we have the panelists and the moderator, Dr. Gajjar, sir? Yes.
Hello.
Yeah. I hand over to Gajjar, sir, now.
Good evening.
Hello. Yeah, good evening. Good evening, everybody. And I'm happy to see you all on this platform. And Sejal, in any field, your efforts are really dedicated and you work with by heart. So I would like to congratulate you for everything, which activities you are doing.
Thank you.
And I'm sure you will go ahead at national level.
Thank you, sir.
So, may I know all our panelists are present here?
Yes, sir, we are here.
Yeah, they are there. Yes, Doctor, just a minute. Huh? They are there. So, abnormal uterine bleeding. We have been talking about this since long time. Just a minute. I have posted this in the group.
Yes, sir.
Some of the other,
Yeah.
this is not being presented.
Yeah.
Can you make it?
Sir, please you stop sharing your screen.
Okay. Okay.
And then Nainika, will you be comfortable sharing sir's screen, sir's PPT?
I'll just share my screen. Host, could you please enable screen sharing for me?
Yeah. Sir, you stop your screen.
I have stopped it. I will unmute.
No, sir, we are still viewing your screen only.
Just a minute, madam. I will.
Okay. Yeah, better.
Yeah. Is my screen visible now?
Yes, it's
Yeah, it's visible.
a slideshow.
I'll just do that.
Slide is in, Sejal. So shall I proceed?
Yes, sir.
Okay, fine. It's not. So it is one of the most common. Next slide, please. So it is one of the most common health concerns of women, and it can present in many ways, either oligo or menorrhagia or even intermenstrual bleeding. Next slide, please. So, to any of our panelists, how would you like to define AUB? Dr. Margi.
Yes, sir.
Yeah, how
So
would you like to
basically-
define AUB?
Sir, in order for proper definition, if you go, it includes frequency, it includes duration, it includes the amount of bleeding. But as for the patient's point of view, I will say any amount of blood loss which is affecting the patient's lifestyle, I think that is abnormal anytime.
Next slide, please. I can't move to the slides from my side. Okay.
Yes, sir. Once you
So
tell
the
me, I will.
former definition of dysfunctional uterine bleeding, when we were thinking that it is just a purely hormonal thing and there is no pathology, that has gone. So any bleeding which occurs at the interval of less than 21 days or more than 35 days, which lasts longer than 7 days, and what is more important is the mean blood loss more than 80 ml. You said very rightly that it leads to anemia or it affects the health of the woman. So DUB has gone and abnormal uterine bleeding is now terminology. Next slide, please. So again, we talked about this. Mean duration 28 plus 7 days, average loss 35, 10 to 80 ml, and usually 4 days. Next. So how common is it? Any of our panelists? How common is it? What is the prevalence? Am I audible?
Yes, you're audible. As per
Okay.
our OPD, I see some 20% of patients who come with this complaints, and it is more common in adolescent age group and perimenopausal age group.
So next slide, please. You are exactly right. 17 to 20% of the women, they come to our outdoor for this abnormal bleeding. And out of this group, 17 to 20% is in the adolescent age group. And we know nowadays PCO, and these are the patients who come with abnormal uterine bleeding. 50% of them are in the perimenopausal age, and most of them, they are in the reproductive age group. Next. So there is a well-known classification for this. So may I talk to Dr. Anjali? Or may I talk to Dr. Shevali? Or Nikita?
Yes, sir, I'm here, Dr. Shivale.
Yeah.
Actually, palm coin
Yeah,
classification.
next slide, please.
palm coin classification is the most practical one for AUB. Here in palm, we have
I think network is not clear from madam's side.
Okay, I will read. So, look into
Madam,
these
you are not
words.
audible, madam. Anuradha, ma'am.
but okay, I'll see.
Yeah, okay. Now we can hear you.
Anuradha, madam,
Yes, ma'am. We can hear you, madam.
please go on.
Yeah, she.
I
again
think she's
also-
having some network disturbance.
Yes,
Okay.
yes. She again.
So, Dr. Suresh is there.
Yes, sir. Hello, sir.
Yeah. So please focus something on this palm coin classification.
Yeah. That the palm coin classification recently introduced around 6 to 8 years back, and that had been divided in the structural causes, structural or the histological causes, and each causes, and actually that made the acronym P for the polyp, A for adenomyosis, leiomyoma, and the malignancy. So these are the structural causes. Rest coin, like coagulopathy, ovulatory dysfunction, endometrial causes, iatrogenic causes, and that N is for not yet classified. So it's an acronym for all those causes, and that had been commonly used as a palm coin classification.
Do you agree with me that this classification has no relationship with the age group? Say, for example, ovulatory dysfunction are common.
Yeah.
In the pubertal age group and perimenopausal.
Right, sir. Yes, sir. Yes, sir. I
So,
do agree with you. But that should common with all the age groups, because that
agree. But it includes all causes.
Excludes the, yes, sir.
Almost.
And
So
excludes the pregnancy, obviously.
Yeah.
Exclude the pregnancy, obviously.
Yeah. Next slide, please. So nomenclature is like this, and whatever pathology is there, we can write like this. Next slide. So we have discussed about this, and now we'll directly go to cases. 35 years lady, 2-child, sterilization has been done, and she comes to our clinic with history of irregular bleeding and even intermenstrual spotting since last 2 months. And there is a history of dysmenorrhea. She looks anemic. The platelets are normal. So what will you do?
I think for any case, first thing will be ultrasound and examination,
Madam,
examination of cervix.
Sorry to interrupt you, madam. Will you go for the history in detail?
Irregular bleeding, intermenstrual spotting, this manner. Yes, sir.
Yes, sir. First,
Is she taking any drugs?
Yes,
Say like
yes.
warfarin?
we have to rule out the iatrogenic causes also.
Yeah, that
Yes,
is
sir.
right. It's sometimes, these patients, they have got drugs in their pockets, and when you ask them how has she taken, the commonest problem is withdrawal, irregular bleeding, and that is because they are not taking the drugs regularly.
Right.
Sometimes you see the commonest mistake that has been done is it prescribed progesterone for 3 days, 4 days. And then she comes after 7 days. And the moment her progesterone intake has been disrupted, she will again bleed. So she will think that, she will not know that this is because of the withdrawal or irregular drugs which she has taken. But still we have to take the detailed history. Obviously, clinical examination is a must. So on clinical examination, cervix is normal. Uterus is antiverted, just bulky. Fornices are clear. Next slide, please. And you will directly go for the ultrasound. Fine. Dr. Margi.
Yes, sir.
So this is the picture. Tell me, what do you see here?
So there is a lesion inside the cavity, which includes two differentials, basically polyps or a fibroid. But as you have already mentioned, there is a vascular pedicle that is a very common for polyp, and fibroids usually have a peripheral vascularity. Another differentials will be if she has a previous pregnancy, any retained products.
So we will rule. See, we are not going to include anything related to pregnancy in this session.
Yes.
We exclude it because
Yes.
that is to be excluded first.
Yes.
Agree? But now this is the picture. Now what will you do?
So I will suggest hysteroscopy for the patient.
Anything else? Any other investigations which you are having with you? Will you take help of that, or directly you will go with the diagnosis of polyp?
No,
Next
sir,
slide,
as you
please.
have clearly mentioned that we need to rule out other causes also, which includes
Okay, fine.
like drug and coagulation profile, obviously.
Dr. Anuradha.
Yes, so color Doppler can be done. Color Doppler can be done in this case.
So next
And
slide,
we have to see the single vessel supplying to the polyp.
Fine.
To differentiate it from
So
other
this is the
pathology.
color Doppler. Would you go for something else? Next slide, please. Nowadays, our machines are so good and so sensitive. 3D.
Yes, 3D.
So that will tell us what is there and where is it. Still, you would like to go ahead. Suppose this is a case of infertility. Or you are still in doubt that this is slightly irregular. Next slide, please. Yeah, what is this?
Saline infusion. Sonography. That is
Sonohysterography.
sonohysterography. Yes.
Especially to differentiate it from malignancy.
Malignancy.
Okay, next slide, please. So it's a localized overgrowth of endometrial tissue. Glands are there, stoma and blood vessels. You can see the specimen. And what have they done?
Hysterectomy.
Okay, her age is 35.
35.
And this is very common thing in reproductive age group. Usually benign, but they are symptomatic. So do you think that any other pathology exists with this in the specimen? Dilated vessels?
It looks like adenomyosis because of the myometrial.
The myometrium looks thicker.
Okay. Next slide. So what are the other conditions which can mimic like this? Dr. Anuradha?
Yes, leiomyomas are common. Like Figo type 0 leiomyomas can be diagnosed wrongly as a polyp. Also, there are other causes like endometrial hyperplasia, because polyps are also seen in a hyperplastic endometrium. They are because of hormonal disturbances. And even sometimes we have to differentiate from endometrial malignancies. And clinical
Obviously,
examination.
we have to rule out the cervical pathology.
Yes, yes.
So, next slide, please. Suresh sir.
Yes, sir.
Her age is 35.
Yes, sir.
Uterus is not showing any signs of adenomyosis.
Right.
Simple polyp. What will you advise?
Definitely, removal of that polyp should be suffice. So I think that can be done hysteroscopic, or even otherwise also that can be removed by doing a simple DNC with the polypectomy.
Sejal, I have faced one difficulty. Dr. Sejal, while after removal of this polyp, how do you remove these pieces?
If it is a large polyp, as I already shown in video, if you cut the pedicle, then the polyp will remain inside and it is difficult to remove from the very small diameter of the internal os. So what we do, we do the pieces of the polyp inside the cavity, and that this can be removed automatically with the flow of that irrigation fluid flow once we remove the whole assembly. We do not need to remove each and every pieces of that left behind. They are very tiny and can come out automatically. Just a patient has to be counseled that she may feel some tissue coming in the menses in a little bit of discharge, which is she has to consider it as a normal. And few material you can get it with the either the DNC curettage or the ovum forceps to just for the biopsy. So even if there are few pieces left, 1 or 2, 3 inside, that is no harm. It won't cause any.
If you cut pedicle directly, then these difficulties arise. But as you have shown in that video, you go on slightly doing all pieces gradually, then come to the pedicle. Which one is better?
So nowadays studies have shown that even you can remove the entire pedunculated fibroid inside the cavity, it will come out by its own, it will dissolve by its own because you have cut off the vascularity. So there is a debate going on. So right now it is not, but we have the tendency to remove the all specimen because we have to show the patient that, okay, we have done complete.
Okay, fine. So will you have to dilate more, 10 number, 12 number?
But then the fluid will come out.
No, sir, we
No,
don't.
no, no.
We don't dilate more. We make the pieces inside because majority of these are the infertile patient and or maybe the desiring future fertility. So we would not like to damage more cervix. So
yes, fine, very good. So these are the, some tips which you have given to the audience. Next slide, please.
And again, I think.
Yeah. Yes, sir. Yes, sir.
As is an endometrial polyp, that means there is some sort of endometrial overgrowth. So, such patients can be offered minimum dosage of the cyclical progesterone so that the polyp or this overgrowth will not recur. That should be also considered after the hysterectomy.
Next slide, please. 41 years aged, menorrhagia, dysmenorrhea, moderate anemia, family is completed. Obviously, clinical examination you are doing, cervix is normal, but uterus is bulky. Exclude the pregnancy. I am not going to talk about pregnancy during the whole session. So that has been taken for granted. So 14 to 16 week size uterus, symmetrically enlarged. Dr. Nikita, what will you do?
Yes, sir. As we said that we will go for the next step, ultrasound examination of the patient.
Next slide. Next slide. Yes, go on.
For the ultrasound, we would right from the clinical signs and symptoms, either we suspect either adenomyosis or it might be a huge fibroid, single fibroid, which might lead to this enlargement of the uterus. So we will see look for the signs of the adenomyosis on the ultrasound, like enlargement of the asymmetrical enlargement of the uterine wall, either posterior wall is thicker than the anterior wall, or there might be other signs like myometrial cyst, isolated calcification in the myometrium. This might give us the signs or clues of adenomyosis, or it might be a focal adenomyoma as well.
How do you differentiate focal adenomyoma? Rather, I would like to say focal adenomyoma
yes, sir.
And fibroid.
Sir, a fibroid is a well capsulated lesion. So, and it is more of a hypoechoic lesion on the ultrasound rather than in case of adenomyosis, it is a heterogeneous lesion and we cannot differentiate it as easily as compared to rest of the myometrium as in case of fibroid. And with the peripheral vascularity as in case of fibroid unless it is degenerated.
Dr. Lalita, will you focus something on this? How will you differentiate localized adenomyoma from fibroid? Will you take help of some other technology?
So Doppler,
MRI?
MRI can differentiate. Very well differentiate.
Sejal will agree with me that removing fibroid, myomectomy, laparoscopic myomectomy is something easier in comparison to adenomyomectomy. Sejal, what do you say?
Definitely, sir. Definitely. Adenomyomectomy, we try to avoid operating as far as possible. It is the last way.
This has to be clear before we put laparoscope inside. Diagnosis has to be there. Agreed?
Diagnostic has to be clear.
So next slide.
Adenomyosis is usually associated with endometriosis and severe pain syndrome. And it is usually like focal adenomyoma are majority are the posterior wall or the near the fundus. And can be anterior wall, but like can be majority of the time it is posterior wall or the fundus. If you put the color Doppler, there is a heterogeneous blood flow all around, all in the substance of the adenomyoma, while there is a peripheral vascularity in the fibroid. Fibroid margins, if you want to measure the exact diameter, it is easily measurable in fibroid because there is a clear-cut margin, while in adenomyoma, it is diffuse. So with the myometrial tissue, so exact margins are not measurable, and it is not clearly, appreciable areas of the adenomyoma. Second thing is it is we have to see to it other like transformation zone in the ultrasound.
Fine. Endomyometrial zone,
Junction,
and that
yes.
is usually more than
3D
12
ultrasound.
millimeter or something.
That may also help us in diagnosis of, may not be in all patients it is disturbed, but like in adenomyosis, like invading through the endometrial cells can have the disturbed transformation zone.
Fine, fine. Next slide, please. So this uterus is very bulky, almost 12 centimeter by 8 centimeter by 9 centimeter. She is 41 years. Now give me treatment options. All panelists.
We can start with progesterone, and if it works out, Mirena insertion. If progesterone is okay, and if patient wants to go for a final decision or family is completed, then hysterectomy. That will be the last step. Usually, progesterone works better in menorrhagia, but as far as the study is concerned, the dysmenorrhea part, usually progesterone doesn't work well.
I would like to give next slide, and then give your comments. Next slide, please. Okay, where is the cavity and where will you go for? Means how will you manage this?
So this looks like myometrial cyst, is it?
Agreed. Can you define cavity?
It has this typical S-shaped pattern which happens with adenomyotic cases. I mean, it's difficult to define. Yes, I agree. While Mirena insertion, as I said, it will be difficult to get the cavity because of the
distort.
Yes.
14 weeks uterus, cavity is distorted, Mirena insertion is difficult. What will you now? What are the other options? Forget about medical.
Like whether she wants to conserve fertility or not, that will be the
first question. How long will you continue her with the hormones? Bulky uterus, very bulky.
If she doesn't want fertility option, I think we can give her hysterectomy as an option.
Fertility is over.
Then, sir, I think we can advise her hysterectomy.
Any other option?
So I don't think adenomyomectomy is possible in a diffusely enlarged uterus. At the same time, if the fertility is not a concern, I don't think adenomyomectomy is an option for a patient who doesn't want to conserve.
41 years,
We can give
adenomyomectomy.
Dynogest. We can think over giving her a Dynogest. That will
Okay.
reduce her pain symptoms also.
But will it reduce the size of the uterus?
No, it won't. It won't. Even if they come say that 30% reduction in volume, but that doesn't reduce the actually size. It is a shrink overall all around little bit, but it doesn't help in reduction of the volume that much.
So if her childbearing is over and very large uterus, 14, 16 weeks uterus, even
Sir,
sometimes
if I am
larger
41,
than that.
I would like to still preserve this in my uterus, sir. I would not I will go for Dynogest. Not the hysterectomy. So if I am choosing for myself a medical management, I will definitely offer that to my patient also.
Fine.
And only thing here is this, sir, she is only having the 7 gram of hemoglobin, which is not acceptable range. So that has to be corrected and she has to be counseled well that if she keeps on bleeding so much, then she will end up with hysterectomy.
Fine. So anything that interferes with her health in general for a longer time and a routine activity is disturbed, most of the patients, they come to us with a request of hysterectomy in such case. Because they are tired of the symptoms. Anyway, next slide, please. She has menorrhagia since last 2 years. Male child, one male child. Cervix is normal. Uterus is enlarged. Obviously, you examine her clinically, we'll go for ultrasound. Fine. Next slide, please. And you see this picture. One child wants to preserve childbearing. These are the fibroids. Madam Anuradha.
Yes, sir. Actually, there are multiple fibroids and all types of fibroids are seen. So before going for any decision, I will like to go for a 3D ultrasound and mapping of fibroids. And
But almost say these are the 4, 1, 2, 3, 4, 5 fibroids are there. And most important is one is in the cavity.
yeah, yes.
The thing that is near the cavity, it gives more trouble.
Yes.
So what will you go for?
So as she wants fertility, it is better
Yeah,
to
she wants
remove.
fertility, obviously.
Yeah. Yeah, then submucosal fibroids, they must be tackled first. And
Fine.
those intramural fibroids, if they are less than 2.5 centimeter or 2 centimeters, then maybe they are left as it is.
But
May
she's
not
symptomatic.
be.
She's symptomatic.
Because of intramural.
Yeah,
bleeding and
mostly it
pain.
is because of submucosal fibroids definitely.
That has been
we will-
out.
we are-
That has been out.
Yeah, that is out. Yeah.
But
And
still her
then if
symptoms
she
persist.
wants immediate fertility, if she does not want, then maybe we can go for GnRH for 3 cycles and progesterone.
Ulipristal.
Ulipristal also can be given, but if
Temporary.
progesterone does not help her, then I'll like to go for ulipristal because there will be endometrial hyperplasia again with the ulipristal.
Myomectomy.
Yes, if the fibroid size is more than 3 centimeter, then so if it is she wants fertility, then definitely.
These 5 fibroids, one is out, 4 are there. Which fibroid gives which symptoms, we do not know. Still she has symptoms and she wants to preserve her childbearing. Sejal.
We shall try to remove all those fibroids.
Hello.
Sir, I will agree with sir. Suresh sir, I will agree with you. I will try to remove as many as fibroid as possible.
Once we put the scope, then we should try our maximum remove all those fibroids, because all those the medications are not really going to help her, and she may have to go for another surgery rather than once we put the scope, we should try to remove all those fibroids, and most of the time those ultrasound underestimate the size.
Her concern is to have a child.
Yes, sir.
So,
yes, sir.
Will you switch over to infertility treatment planning, or will you remove all fibroids and then start treatment? These are the fibroids, 3 centimeters, 3 fibroids.
We should remove it and then offer her the treatment for the infant.
And suppose you are aggressively treating her infertility and she becomes pregnant, I don't think there is anything wrong in it.
Yes, sir, not maximum. She will need an elective C-section at 37 weeks, 36 to 37 weeks before she starts labor.
I think Dr. Pavanjit has something to say. He's saying mifepristone works in few patients.
Ulipristal works in few patients.
Mifepristone, there is a study by Dr. Alka Kriplani, ma'am. That's what he's been saying.
But no other planning like uterine artery embolization. No.
No,
For
sir.
these
If
two,
they want fertility, then
two
no.
fibroids are there. No.
No, sir, no.
I think
If
it's a
they're
difficult
planning for
case.
fertility.
We will leave to God, treat her infertility aggressively, and if she becomes pregnant, I don't think that these intramural fibroids will cause any problem. Problematic thing was submucous fibroid, and that has been removed. Next slide, please. Large fibroid obliterating the cavity, vascularity is there. She desires to have another child.
Myomectomy.
Okay, fine. Laparoscopic myomectomy. Next. So, how will you differentiate fibroid and polyp? I think Dr.
Madam already explained.
Yeah, she has already said. But submucous fibroid, which is projecting in the cavity, and you are going to tackle it with hysteroscopy, what factors will you keep in mind? Next slide.
Size.
You are going to tackle with hysteroscope.
Yes.
Can you manage all fibroids which are projecting in the cavity with the hysteroscope?
It actually depends on the expertise that how much duration the surgeon will take. Usually less than 4 centimeter, they said it's easier to tackle through hysteroscope. More than that, it's difficult to tackle through hysteroscope. But there are few cases that people have done up to 6 centimeter and in 2 settings also. It completely depends on surgeon.
Any other comment?
So multiple fibroids, if they are more than like 1.5
No, single
centimeter.
fibroid, submucous fibroid, you are in dilemma whether to tackle it through the hysteroscope or going with the laparoscope.
Then 2-stage surgery also can be planned. If it is less than 4 centimeter, then 2-stage surgery can be planned. That will be safer for the patient.
Do you agree with me that it is the portion of the fibroid which is projecting in the cavity and the part of the fibroid which is in the myometrium that will decide the root as well as the base of the fibroid?
Yes, sir. True, sir.
Yes,
The
yes.
FIGO classification is a must. Which type of fibroid?
Okay. So it depends upon so many factors. Next slide, please. Puberty menorrhagia, 15 years. She has continuous bleeding since last 1 month. No history of amenorrhea, 5 gram hemoglobin. I think this case has been discussed by Madam for medical management. She is admitted in emergency. Now what will you do? Her hemoglobin is 5 gram. She is bleeding.
first thing medically we have to do hemostasis, like giving her norethistone tablets in high doses to stop the bleeding. Once she has been diagnosed, like it is not any other type of bleeding, only
Agree.
hormonal
So,
imbalance.
Next slide. Would you like to rule out
Coagulopathy can.
Yes, yes.
Because that is the first thing that should come to our mind.
Mm.
And there are so many conditions which can lead to such type of bleeding. Von Willebrand disease, prothrombin deficiency, hemophilia, leukemia, even severe sepsis, ITP.
Or if she's in any anticoagulant drugs, that is.
Yeah. So we have to ask all these things in the history. Next slide. So these are the things which are to be asked. Dental bleeding, bruising, epistaxis, family history of bleeding, and these are the tests which we will advise at first. And obviously her hemoglobin is 5 grams. So naturally. And then the next step will be to control the bleeding with the hormones. And obviously tranexamic acid will help. Next slide, please. 48 years. She is bleeding since last 7 days. Her last period was before 2 years, means this is postmenopausal. She is obese, diabetes controlled, not hypertensive, clinically not anemic. What will you do?
USG, pap smear, and endometrial biopsy.
Local.
Fine. Next slide. Fine. So this is the USG image.
Endometrial hyperplasia.
Hyperplasia.
So Lalita madam, cut off for the endometrial thickness. And the postmenopausal bleed. This is 15 mm.
18 millimeters. 17,
7 millimeters.
7.
It should be less than 7 millimeters.
More than
आप कौन बोल रहे हैं? For
viewers,
postmenopausal 7 millimeter, it is
Yes.
15 millimeter
Fine.
showing.
Fine.
अच्छा अच्छा
Okay.
अच्छा हाँ जी बताइए.
Okay.
viewers, I request you all to mute them. Yeah.
USG shows some cystic area.
Yeah, irregular
Cystic
endometrium with the
cavity-
cystic area.
Cavity looks normal. Not normal, but not irregular.
Not irregular.
Well-defined mass. Next slide, please.
Hyperplastic endometrium.
It can be endometrial hyper. This one. Irregular lesion in the cavity. Cavity is not well defined.
Histopath will decide that.
You would go for biopsy, ne?
Yeah.
Yes.
Under hysteroscopic,
Yes.
Yes, we will advise under hysteroscopy.
are there any chances of migration of these cells through fallopian tubes to the peritoneal cavity and spread of malignancy?
Yeah.
Is it a theoretical or
Mostly, sir, it is theoretical. There are a lot
Theoretical.
of studies they have come up that there is no
okay,
such a
fine. So
spread.
hysteroscopy and biopsy, right? Hello?
Yes, sir. We are hearing you. Yes, sir.
Hysteroscopy,
Yes, sir.
biopsy,
Yes, sir.
curettage, all materials are removed. Fine. Next slide. Next one. So it can be anywhere, vagina, cervix, endometrial, no, revert it back. Go back. Even adnexal mass can present with the postmenopausal bleeding. Next one. So what is more important for us is postcoital bleeding, intermenstrual bleeding, history of some estrogen intake. from somewhere. We do not know. It may be dietary. Now this picture. Fluid in the cavity, postmenopausal age group, low-grade fever, cavity appears blocked.
Yes.
Biometer. What will you do?
Drainage.
Antibiotic IV, CBC.
Drain it.
Drainage.
Fine. And while draining, how will you drain it? With suction?
No, just
Actually, just cervical
dilate and
sternum.
all.
Dilate the cervix.
Yes.
Nothing more.
So under sonographic guidance, we can see whether it is completely drained or not.
No, once you open cervix, I think it will be drained naturally. But try to
Then we have to rule
attempt,
malignancy also.
vigorous attempt to drain and get biopsy and all these things resulted into perforation in one case. Now what will you do?
Culture sense.
She is a aged lady, 75 years. This is a real case which I am telling you. 75 years. She is medical, so many morbidities along with this disease, even past history of CV stroke and pyometra and perforation. Now, perforation. Now,
so we have to see whether it is drained properly or not.
no, it has gone in. This perforation is there, and they tried to keep it conservative.
Yes, better
with
to
heavy
go for
antibiotics. And
Conservative or
conservative management.
Conservative.
Okay, fine. She developed peritonitis.
Open.
Her immunity is very low. She developed peritonitis. So now,
Higher antibiotics.
open.
So if we are not responding to antibiotic, we have to open. If she's
No. She has already full-fledged peritonitis with perforation and acute abdomen.
Sir, we have
acute abdomen need acute treatment.
Laparotomy.
Laparotomy, laparoscopy, whichever the
diagnostic
surgery.
laparoscopy, then laparotomy.
Sejal, will you go for laparoscopy?
We can.
Sir, I will go for laparoscopy.
Partial
And lavage and clearance, and then after all clearing the all pockets, we'll put a drain, whiteboard drain, and
Will
we'll
you keep
send the
uterus?
culture sensitivity.
Will you keep uterus?
Patient is not in sepsis, definitely will remove the uterus. If patient is stable, then only. If patient is not stable, then we'll just do the clearing of the pus drainage and put the drain till the patient become capable enough to withstand the anesthetics, that surgical risk.
I joined in the middle of the surgery. Laparotomy was done. The main problem was it was so much friable and soft.
Friable.
If you touch it, it will come in your hands. Now what will you do? If you apply clamp will crush the tissue and come in your hands.
Uterine artery ligation and hysterectomy. Uterus has to be removed. Then, if it is so much friable, something will come out every time.
You can't
will
apply
slough
clamp.
off. Eventually, it will slough off and keep
it will keep on pouring in abdomen. So it is better to take
We
it
have
out.
to remove uterus. Agreed. I agree with you. But the thing is that it was so friable. She was in a bad condition. We do not want to keep that focus inside. Focus of sepsis. Otherwise, she will be more deteriorated. And that perforation also is there. And so hysterectomy was done, but without clamps. Without clamps. Just tie the things. And uterus was out. Don't worry if you keep cervix inside. Because uterus is the main focus. Anyway, she stayed in ICU for 10 days. Then came out because she had multiple problems. ultimately she survived. Next slide, please.
We thought ultimately she.
That's why we call them in middle.
Anybody.
Call sir in middle. That's the main.
Anyone, please share your comments. Would you like to differ from these or previous slide, please? Previous one. Any
Sir,
other treatment
only
plan you would have
one
suggested?
concern. Sir, one concern is there. Before doing hysterectomy, we should be sure that this pyometra is not secondary to some malignancy.
That
there can
specimen
be
will show us.
cervical.
No, we removed it and specimen will show us.
No, but the hysterectomy will be difficult in cases of if it is CA cervix.
Agreed. Agreed. But there are during surgery there was no other. We palpated para-aortic nodes and everything. The main problem was that why I was called in the middle of the things, because patient was pushing so hard, bowels were out. It was difficult to search uterus inside. And if you catch uterus, it will come in your hands. So anyway, next slide, please.
Sir, we are running short of time. We are.
Sir, this is the last one.
Okay, yes.
She came with, there is no bleeding, only history of pain in abdomen. She consulted before 2 years with the same complaint. At that time also she was advised pap smear and biopsy. Just a minute. She didn't come up for follow-up. Ultrasound showed this picture. Still we were not satisfied and set up her for CT scan. And that showed endometrial malignancy with para-aortic lymph node involvement. Do you agree that endometrial malignancy can occur with metastasis without postmenopausal bleeding? This has happened. Okay. Next. Next slide. Thank you very much. Thank you. I appreciate all my panelists for making this session very interactive. And I got so many options from you, treatment options, and very nice suggestions. Thank you very much.
Thank you so much, sir.
Thank you, sir.
Thank you to learn a lot.
Yes, sir. Panel discussion was really, really very interesting, case-based, and we thoroughly enjoyed. And many have joined in between, and we have crossed total more than 70 participants in between. Thank you, sir. Thank you so much, all the panelists.
We have one question from the audience. Usha Rani ma'am has asked, can we repeat medical curettage with norethistron for more than 1 month? That was the question asked by her, that can we repeat medical curettage with norethistron for more than 1 month? Like more than 1 month can we?
Yes.
And for how many? For how long we can continue medical management? That's the question.
See, if you give progesterone for more than 1 month, the time will come that required progesterone will be less and she will have breakthrough bleeding.
Breakthrough bleeding, yes. So that's how long?
Still you forget breakthrough bleeding and still continue progesterone, and that bleeding will stop. So we can give progesterone for 3 months, irrespective of the breakthrough bleeding.
Okay, sir. Thank you, sir. Any questions from the audience? I think no.
So what is your experience with Dynogest?
It's a really good.
We can't give it more than 6 months.
These trials, they have said that initially 2 months, 3 months. But these are the trials, and after 4 or 5 years, they will be able to say that we have given for 6 months or something like that.
I have heard through the laparoscopic surgeon who does endometriosis that after giving Dynogest, the surgery is very difficult. That we do not get any planes and the fibrosis is so much. So have you ever occurred with such type of cases? Have you seen any?
Dr. Sejal, a good laparoscopic surgeon will not have any difficulty. irrespective of any type of fibrosis. So these are all
Usually that
theoretical.
we encounter for the myomectomy, but for hysterectomy, I don't think any much of a tissue
It doesn't
Yeah.
make any difference.
Even
Yes.
those patients who have been given Dynogest for adenomyomas, they really don't shrink adenomyoma much, but it really causes it, it makes it very soft and friable. Therefore, removing that adenomyoma becomes very difficult laparoscopically. So those patients who've been given Dynogest and they're going for adenomyomectomy is a comparatively tougher situation as compared to the patient who has not taken any progesterone before surgery.
And do we have any role in GnRH analog?
Similar case scenario.
Okay.
I
And
think my session is over. So it will be left to Sejal to go on, whatever it is. But panel is over.
GnRH analog has a madam, Lalita madam can.
Yes, 3 injections. 3 injections can be tried. GnRH analogs, they give really wonderful results. My sister, she had a fibroid and she was a case of previous 3 seizure, 100 kg. So we have given GnRH analogs and we could save her uterus. She was free of symptoms. At least size may reduce or may not reduce, but the symptoms and it does reduce. So GnRH analogs.
How long will you continue that? We can give only 3 doses, and after
3
that,
doses in case of perimenopause.
After
Do you
that,
agree
have to
that
fix the doses course.
she will need add-back therapy? If you give 3 doses of GnRH agonist, add-back therapy has to be there.
Yeah. So this will only buy some time, as Dr. Surat said correctly, that to improve the hemoglobin or to plan the surgery, or if they are the NRI patients want to come back for the surgery with the proper timing and planning. So for them it is okay, but otherwise permanent cure is not possible with the GnRH. She will again bleed after like few months or so. Only the perimenopausal women where we are expecting her to to get her menopause soon, we can try, but still in there the osteoporosis chances may increase, so we have to be very judicial using GnRH analog for abnormal uterine bleeding, rather than to put Mirena. That is best. That we can once we achieve the menopause, we can still keep it for 5 years, no harm.
Even there have been studies with the use of ormeloxifene. Back in our PG, we used to use a lot of ormeloxifene. But these patients also respond very well. And the best part is that the dosing is very less. Twice a week also, ormeloxifene works very well. But in spite of that, in DUB, AUB, but in these patients, they usually get ovarian cysts. Complex, simple ovarian cysts though, but large ovarian cysts they get, and breakthrough bleeding is too much. But otherwise, if you ask regarding the drugs per se, ormeloxifene has a very good effect in these patients.
Yeah, correct.
Combination of therapy is required. For some time you can use this, then after that.
Yeah, correctly said, ma'am.
Like Sir said, buying time.
Yeah.
Either she will reach menopause or we might have to operate.
Yeah. So Nainika, I would like you to conclude. And thank you so much. Special thanks to you.
Thank you, Sejal ma'am. Thank you, sir, for your inputs and your guidance, and all the panelists who were so interactive within the session. And I thank you, Sejal ma'am, for giving us all this opportunity to meet on this platform. And we wish you all best of luck for your future endeavors, and we are all there to support you.
Thank you. So thank you so much, Ahmedabad Society, Aurangabad Society, Nashik and Navsari Society for joining hand. And thank you all the president secretaries being here, all chairpersons, faculty, and the entire brigade of panelists with the moderator, Dr. Narendra Gajjar sir. Thank you everyone for being there. And it's a wonderful program. We'll share the photographs soon and probable the recordings also. Thank you.
Thank you, madam.
Thank you.
Thank you so much,
Thank you very much.
Thank you, ma'am.
Thank you, everyone.